So very good evening to everyone. And at the outset, before I begin, I'd like to take this opportunity to congratulate Shyam sir and the organizers for actually breaking the monotony and bringing us all together physically. I think we've all been fed up with webinars, so it's nice to actually gather everyone physically. So I have this honest task of discussing on the role of neoadjuvant chemotherapy in breast cancer, probably in early breast cancer. So I thought we've already had a lot of talks on hormone receptor positive subset and in the triple negative breast cancer and HER2 as well. But there's a lot of controversies, especially in the triple negative breast cancer subset, which is probably why I thought we'll focus more on that and also on response adaptive therapy. So I have a distinguished set of panelists, both national and international panelists, to help me through with the panel discussion. So let's get started right away. So this is a 38-year-old practicing gynecologist with P2L2 premenopausal lady with a complaint of left and left breast for 1 month duration, presented in the oncology OPD and had an FNAC which is suggested an IDC. And on examination, palpable lump around 5 centimeters in the retroiliac region with palpable mobile left axillary lymph node. So biopsy report, that's it. It's an IDC grade 3, triple negative. So, probably I'll just begin with this. We've already talked about the molecular subtypes of triple negative breast cancer, but do you think it has any relevance as far as treatment is concerned or therapeutic relevance of the molecular subtypes of 3 and BC? We'll begin with Dr. Sujana.
Although we are not doing it,
Okay. I can hear you, but
although we are not doing it in clinical practice, but this has got a clinical significance in terms of response to immunotherapy, with the immunomodulatory type having more likely of PD-L1 expression and basal-like expression having more likely of BRCA positivity.
So, do you think that we're actually ready to use that in clinical practice to use a judgment? Say, for example, if you want immune checkpoint inhibitors, you probably want to select an immunomodulatory subtype. Do you think that is, are we there yet?
It has not come into.
I think we are not doing it in our routine clinical practice as of now, but maybe I do not know. I think it's still more of investigational thing. Routinely, it's more of investigation.
So fair enough. So I think we had actually done it. We done check for the androgen receptor positivity in patients with triple negative breast cancer and look at targeting the androgen receptor as well. But there's only phase 2 data to that tune, where the people have looked at using either androgen receptor blockade with abiraterone and enzalutamide as well in breast cancer. So that's just food for thought. Not in the neoadjuvant setting, but it's in the metastatic setting. But I think, like all the panelists have rightly agreed on, I think we're not yet there as far as translating it into practice. It just exists as far as knowing about the molecular subtyping. So this was the finding of the PET scan. And let me again get your thoughts on that as well. Do you think, what are the indications for doing a PET CT as far as staging workup is concerned in your practice? Any of the panelists? Dr. Mehdi?
Yeah. Although there is no standard recommendation, but in young patients, most of the patients we are doing, and in fact, if we do not suggest, also patients themselves are doing the PET CT. So I think now the time has come, we cannot avoid PET CT in this type of situation.
So I think like rightly said, it's probably become more of a status symbol. I've got my PET scan, have you done yours? But I think if you look at the recommendations and guidelines, I think it's more clearly for the locally advanced breast cancer starting from stage 3B, even if you look at the HGCC recommendation or even for NCCN as well. For early breast cancer,
if the patient comes to us without a PET CT, we have to tell that patient that the PET CT is not indicated in your case. Then it is up to him if him or her if he wants to get it done. But we should tell the patient that it is not recommended in your case.
So your shared decision making is what you're calling it. Probably an informed decision. Yeah. So Professor William, are you there? And if you can hear us.
Yes.
Yeah. So your thoughts on the role of a PET CT scan in early breast cancer, be it even early triple negative breast cancer?
Yeah, I think the broader question is whether we do imaging or not, and the answer is yes. I think there's still disagreement about whether it should be PET CT or CTs and bone scan. PET CTs are often many times more expensive than a CT bone scan. So it's not uncommon for CTs and a bone scan to be done rather than a PET CT. But I think the bigger issue is, yes, imaging should be done in somebody like this.
I think, when we talk about upstaging the disease as far as early stage breast cancer is concerned, be it even triple negative breast cancer, doing a PET CT doesn't actually, we again had this data where we looked at patients with early stage disease, even when checking on a bone scan, only around 10% had, we were able to pick up bone metastasis only 10%, even in the triple negative breast cancer subset. So I think probably that's why, probably you end up over investigating. But like the panelists rightly pointed out, I think we are right now in the era where people actually tend to look at getting a PET scan done for any indication. So and probably in some places it does turn out to be cheaper than having to do a CT chest, CT abdomen, and a bone scan together. So you're probably looking at a single stop investigation to get that done. Any other investigations that you'd want to order for this patient, Dr. Mohit?
I guess all the relevant investigations have been already, mammogram has been done.
Yeah. As in any other genetic information that you would like to know for this patient. Do you want to do genetic testing for this patient? I'll be more precise.
Yes, genetic testing has to be done.
Okay.
It should be done.
So, I know, for anybody with triple negative breast cancer, we always look at getting a genetic testing and counseling done for the pre-test and post-test counseling. Is there any indication where, you would not want to do a genetic testing in a particular individual with triple negative breast cancer? Or is it across the board? Because, NCCN mentions a cutoff of less than 60 years. So if we have somebody with 65, 70, does that mean we wouldn't offer them genetic testing?
If they have other risk factors, we'll definitely consider it.
So you would consider probably
if there is strong family history.
I mean, I do not get it done routinely. We really discuss it with the patient. She wants to get it done, and only then we go ahead and do it, rather than just directly advising a young female triple negative. We just discuss it that you should know getting the test done and the implications of the test. Only then she should get the test done.
So ideally, yes, you would probably need to have a genetic counselor and talk about pre-test counseling and post-test counseling, as well as the implications of having genetic testing done. But I think across the board, it should be offered. And, that's how what the recommendations are as well. Professor, if you can hear us again. So, do you routinely offer genetic testing to anybody who walks into your clinic with a diagnosis of triple negative breast cancer?
For that subset of patients, we usually do. And obviously this patient is younger, so there'd be little disagreement about obtaining genetic testing. And of course, the other implication is if she has a BRCA2 mutation, somewhere along the line, PARP inhibitor might figure into her therapy.
Yeah, I think we're all in agreement on that. So, slides move. It's moving on the system, but it's not moving on the screen. It's not moving on the screen, but it's moving on my desktop here. All right, great, thank you. So I think those are the indications. If you go by the recommendations across the globe, this patient had a germline BRCA mutation as well. And I think as far as definitions are concerned, early breast cancer, Dr. Sujana, if you want to touch on that, define as to what early breast cancer, what operable LABC is.
Yeah, in a triple negative breast cancer, any tumor more than 1 centimeters or node positive irrespective of tumor stages less than 1 centimeters is usually considered as early breast cancer.
Okay, I think it's anything up to T2 and N1 is considered to be early breast cancer. Any T3 or N2 makes it LABC, and up to T3 and N0, T3 N1 also is considered to be operable LABC. So I think that's how they look at defining it. So I'll probably ask Dr. Novak. I know all the recommendations are probably very clear that anybody with more than 2 centimeter lesions and triple negative or HER2 positive disease, yes, go ahead and give neoadjuvant chemotherapy. So let's say in the Indian scenario as well, somebody walks into your clinic with a 2.5 centimeter lesion. Would you still stick to the guidelines and offer them neoadjuvant, or would you be tempted to go ahead and send them across to your surgical colleagues?
So, sometimes we are lucky that the patients does come to us with that kind of lesion and that kind of disease. So when they turn up to us, we offer a neoadjuvant. But mostly what happens is these patients actually, they've come to us after the surgery. And, you just have to go ahead with the adjuvant.
Okay. The point was, are we really looking at these cutoffs like, to be very stringent? Anything more than 2 centimeters, like, let's say even to 0.1 to 0.2, are we going to strictly suggest it? Or are we going to be more flexible about that, say even up to 2.5 centimeters or maybe even up to 3 centimeters and node negative? You probably might want to.
I'm more inclined to give a neoadjuvant therapy.
And the reasons as to why probably you would want to give neoadjuvant chemotherapy, I think you probably ask Dr. Mehdi.
Yeah, regarding that question, whether 2.5 centimeter tumor should receive neoadjuvant chemotherapy, or it depends upon whether patient landed in with the surgeon or it's with medical oncologist. Most of the time we receive the patient after the surgery. So because when we talk to them, then surgeon says that 3 centimeter tumor, it's very easy to take out and we can do reconstruction, we can do BCS, there is no problem. So it depends upon when, where the patient landed.
So I think, you're talking about putting it in a very real life practice and, the perspective as to who the patient lands up with. But I think, if you go by that, especially in the current year of response adaptive therapy, where attaining a PATCR is both prognostic and predictive as well.
Yeah.
You're absolutely justified in going ahead and doing neoadjuvant chemotherapy
Yes.
for anybody with more than 2 centimeter lesion. So moving on to the choice of neoadjuvant regimen, we've heard from Dr. Randeep as well on the role of nab-paclitaxel, and I'll just quickly take you through the PATCR. Well, here is the data that shows that it's not just about having a higher PATCR, but does translate into an EFS benefit as well across the board. And this is a CTNU of PC pooled analysis as well, which shows you that across the board, not just the HER2 positive subset, but also the triple negative subset as well. So I'll move on quickly to this debate. Nab-paclitaxel versus paclitaxel in your practice, Dr. Sujana.
We are not using nab-paclitaxel in our setting, sir.
You use a lot of
No,
nab-paclitaxel?
no,
You don't?
no.
Okay, conventional. Any takers here for nab-paclitaxel?
No, we are using.
Okay.
We are using.
Anyone else on the panel?
I'm using conventional paclitaxel.
Conventional
but,
paclitaxel.
I was just seeing the data which Dr. Randeep also presented. HER2 positive and even the Harun positive, we are getting more of a PCRs, though the delta is somewhere about 3%, I believe, 3 to 4%. But probably from tomorrow, I'll be more inclined to go ahead with the nab-pacli.
Okay. So I think, Dr. Randeep, you also showed us the data from the ETNA study. This is the other study, the Japan Septo study, which is also shown that there's an improvement in PATCRs when you use nab-paclitaxel. So I mean, if I can probably quickly ask the audience as well, a quick show of hands. Govind sir, Purvish sir, Sham sir. I mean, do you routinely use nab-paclitaxel? Okay, Govind sir is agreeing. Purvish sir, nab-pacli as well. Okay. So yeah, I think if you go by the data and also by the PATCR rates, I think you justified in offering nab-paclitaxel. Let's get Professor William's thoughts as well, if he's here. Professor William.
Yeah, so in this setting, we're more likely to use immunotherapy per keynote. So we would follow that regimen and not necessarily preferentially use nab-paclitaxel, but carbotaxol followed by AC with pembro if the tumor is roughly 2 centimeters or more. So that's sort of our standard.
Great. So I think, you're using the keynote 502, but unfortunately, I'm not sure most of our patients would actually be able to afford that regimen. But yeah, having said that, that's probably the gold standard right now. And what about the role of platinums? I think, this is, being debated on for ages and ages. So again, Dr. Sujana, will begin with you. You convinced with the data, do you routinely use platinums? And if so, is it dose dense, 3 weekly, how do you use it?
So, sir, with the recent update of the brightness EFS data, before that, we were doubtful about the role of carboplatinums or platinums in the TNBCs in relation to BRCA mutation status. But with the DFS benefit shown now in the ESMO, which has come recently, so we are thinking of using it. We are offering to our patients with weekly Paclica.
Okay, but just to quickly, just to play the devil's advocate here, the brightness study, the primary endpoint was looking at the addition of veliparib, which is a PARP inhibitor, to the combination. And the primary endpoint of that trial was not met. It was a negative trial. So how much would you actually read into a negative trial to pick out the other points and say, okay, that justifies my use of carboplatin in that setting?
But even with the other trials, the addition of carboplatin has improved the PCR rates, which indirectly transfers into the EFS benefit.
So yeah, I think we're all in agreement about that as well. Any differing thoughts from the other panelists as well on the role of platinums? Do you routinely use it in practice?
We definitely routinely use
Okay.
platinum.
Your choice of platinum.
Weekly paclitaxel along with carbo AUC.
Carbo AUC too. Okay. Any takers for cisplatin? Do you use cisplatin? No. Only carboplatin. Okay. I think probably platinum still remains a poor man's PARP inhibitor. I think you can put it that way. And this is the data across the board where you see that there's about a 15 to 20% improvement in the PAT-CR rates when you add a platinum. That's been shown across boards and across meta-analysis as well. But then there comes the debate that it is not actually translated into overall survival benefit. But that's because all of these studies were not powered to do that. The primary endpoint of these studies was PAT-CR. They were not powered adequately to answer that question of the difference in overall survival. So, and this was interestingly another, a debate that happened on an international forum between Dr. Rebecca and Dr. Hochbrugger. And interestingly enough, Dr. Rebecca was for it, and Dr. Hochbrugger felt that probably the additional toxicity was not worth taking in. So, and this is very own Indian data from CMC Vellore showing that it can be done. The PAT-CR rates done by my colleagues Dr. Anjana and Dr. Ashish, and they published it as well, albeit only retrospective data. Again, the treatment completion rates were well to the tune of more than 95%, and the PAT-CR rates to the tune of close to 50%. So I think, yeah, it definitely can be done. We'll get Professor Williams' thoughts as well. Sir, do you routinely use platinums for triple-negative breast cancer in your setting as well?
So in the pre-Pembro era, we would make a decision based on patient age, whether they could tolerate the extra toxicity. We were more often likely to use it in patients who were younger with more aggressive features. Once Pembro, and I acknowledge we have it more available in the US than elsewhere, carbo is just part of the plan. So we're giving carbo in all patients with Pembro.
All right. So I think we'll take your thought on that. So, I know now this has probably changed the way in which you all look at triple-negative breast cancer, the role of neoadjuvant therapy in triple-negative breast cancer. So, this is the data, again, irrespective of the PD-L1 expression as well, it has shown a benefit in the PAT-CR rates. Guys, okay, thank you. So, there's been an improvement in the tune of 15% made both irrespective of the PD-L1 expression, both in PD-L1 positive subset and the negative subset as well. And this was the both interim analysis of the Keynote 522, which has also shown an improvement in the EFS of 84 versus 76%. But if you look at all the other neoadjuvant trials, it hasn't been so promising. So I'm going to quickly pick your brains on that. Dr. Sujana, I'm sorry, I'm just starting with you every time. But why are we getting to see these differences across different trials in the neoadjuvant setting with immune checkpoint inhibitors? Your thoughts on that? Because if you look at the Keynote 522, yeah, absolutely, yes, it's a positive study, always gets celebrated around, talked upon a lot. What about the other studies, where if you can see here, clearly?
Basically, these studies, the partner chemotherapy was changing,
Okay.
and whether they were continued in the adjuvant setting also differed. So there are multiple factors because these two studies cannot be truly compared.
Correct. I think, we're on, and look at the numbers as well. The Keynote 522 was the largest study among all these trials. And again, there are a couple of trials, the Japan New one, the NeoTrip, which only looked at 6 months of immune checkpoint inhibitors. And then again, if you look at, even the chemotherapy regimen, like you rightly pointed out, they were not the same, they were not uniform as well. But let me go into that as well. Say, for example, the NeoTrip PD-L1, they did not complete all cycles of chemotherapy prior to going in for surgery. So that's another reason. So I'll quickly ask you this question. In your practice, do you still believe that probably only patients with PD-L1 should be offered this regimen, or should it be offered irrespective of the PD-L1 regimen? Dr. Mehdi?
Yeah, till we do not have a stringent marker for response of immunotherapy. I think PD-L1 should be considered as a marker. And in our practice, I think we are taking consideration of PD-L1 positivity only.
Okay, you're using that? Okay.
Yeah.
Do all the other panelists agree with that? Because I just showed you the magnitude of benefit, even in the PD-L1 negative subset, where it's to the tune of around 45 versus 30%, again a 15% increase in the PAT-CR rates. Again, I'll just quickly turn to Dr. Randeep, Dr. Purvish.
It all depends on the cost. So if cost is not an issue, patient wants it irrespective of PD-L1, we can offer them.
Yeah,
If cost is making a major concern, we would push for it if it is PD-L1 positive.
I think I would agree with that, but probably Dr. Andip, sure. And even the PAT CR rates are also.
If you have a event-free survival, which is a better parameter, I mean, we want PAT-CR to convert into EFS. And if your EFS is not correlating with PDL1, I think it is for all comers. And then you are giving it in the neoadjuvant and adjuvant setting. So it is not a response assessment based method.
Absolutely. And in fact, if you look at the magnitude of benefit, I've not shown you that slide, but even in patients who did not have a PDL1 expression, the magnitude of benefit was still maintained. And probably, you know, even if they didn't achieve a PAT-CR, you know, those patients actually seem to benefit much more with continuing pembrolizumab as well. And I will get in Professor Williams' thoughts as well. So, Professor, I mean, like, what about the role of PDL1 in selecting these patients in the neoadjuvant setting? What do you do in practice?
Well, we're sort of relieved again that we don't have to rely on PD-L1 because it's not necessarily the best marker. Obviously, in metastatic disease, we still rely on it. But in the neoadjuvant setting, it's triple negative all comers that we think of for Pembro. And again, I think if cost was an issue, we may have to discriminate a bit more, but PD-L1 doesn't really figure into our decision-making for pre-op Pembro for triple negative disease.
I think that's the take home. I think we should probably be looking at giving it irrespective of the PD-L1 expression because the magnitude of benefit has been maintained. Quickly into the adjuvant setting, I mean, like, any role for an anthracycline-free regimen in early triple negative breast cancer, where you do only 6 cycles of Paclitaxel and carboplatin? Any takers to that? Dr. Mehdi?
In young patient, my practice is to go with anthracycline regimen initially.
Okay. Even for early stage disease?
Even in early stage disease, because triple negative disease is even in early stage disease recurrence is
so you're convinced with anthracycline?
Yeah, anthracycline based, then followed by taxane plus platinum.
Okay. Dr. Novak, how impressive is this data? This is also phase 3 data. This is a study called the pattern study, which looked at Paclitaxel and carbo and compared it to FEC followed by docetaxel in low risk triple negative breast cancer in the adjuvant setting. So, your thoughts? I mean, like, do you think you can do that in practice?
I think young patients, I am inclined to go ahead and use the anthracycline. It's more the elderly patients where I might be avoiding the anthracyclines.
I think probably this is good enough data, especially if somebody's got node negative status and up to PT2. It can definitely be offered as considered as a regimen if you believe in the Chinese data, that is. So this patient went out to receive the Keynote 522 regimen. Quickly, I'll just get on to this. So I mean, like, in the adjuvant setting, how do you choose? What would be your ideal choice if you want to offer capecitabine? Would you pick the Createx way, or would you do it the cis-UCC, again the Chinese data, where you give 1 year of metronomic capecitabine? Dr. Mehdi.
Yeah, we are considering that giving capecitabine for 1 year.
But how do you do it? Do you do it for 6 months or 1 year? And what is the dose that you're comfortable with?
The dose, the Indian patients, our patients are tolerating only the lower side of the dose, maybe 1000 milligram twice daily.
Okay, but unfortunately, that dose, if you look at the French study,
yeah, that was a higher dose.
So either you go the Createx way or the cis-UCC way. If you feel patients can't tolerate it, probably 1 year of low dose metronomic capecitabine should be the way. Let's quickly conclude with this. PARP inhibitors. If remember, this patient had a germline BRCA mutation, and you've already used the Keynote 522 regimen. And so, would you be tempted to use PARP plus immunotherapy in this patient? IO plus PARP, or all of the above, none of the above? What should you do?
There is no data for it.
Okay, you wouldn't combine it. Fine, fair enough. Any differing thoughts from Dr. Novak and the other panelists? No? So you don't, you're not inclined towards this data? Yeah, I think probably in the triple negative subset, it makes a difference because, you know, around 83% of patients in this study were triple negative, hormone receptor only around 17%. And very interestingly, I mean, like, and obviously we've had an ESCO recommendation as well saying that, yes, in patients who have a germline BRCA 1 or 2 mutation, yes, this is definitely a valid option. With that, I think I'll conclude and thank my panelists for making it such a wonderful interactive discussion. And also thank Professor William for giving us his wonderful insights. Thank you.
Thank you.
Thank you.